I wish they would put a skull and crossbones on the bottle of Cogentin and call it poison.
Okay.
Or at least put a Mr. Yuck sticker on it. If we think of benztropine as not really benign, then that's also going to be, for us to be able to overcome an obstacle in terms of the management of TD.
That was Dr. Leslie Citrome, clinical professor of psychiatry and behavioral sciences at New York Medical College in Valhalla. I'm Nick Andrews, and you're listening to the MDedge Psychast. Even with the use of some second-generation antipsychotics, addressing tardive dyskinesia can prove challenging for clinicians. This week on the MDedge Psychast, Dr. Citrome joins Dr. Lorenzo Norris to discuss the management of TD. And later, Dr. RK talks about something we could all use a little more of: courage. And now, let's join Dr. Leslie Citrome and Dr. Lorenzo Norris.
Dr. Citrome, it's a pleasure to have you on the Psychast today. Please, go right ahead.
Well, thanks so much for having me. There are some obstacles that we can easily overcome in the management of tardive dyskinesia, but perhaps the very first one is admitting that you have patients with tardive dyskinesia in your practice. TD can fly under the radar. Not everyone has to be sticking out their tongue to have TD. That tongue can be moving within the oral cavity, and we won't know it unless we take a look. And in our older patients who wear dentures, one may wonder why these dentures never fit. And it may be because of tardive dyskinesia. It has not gone away with the use of second-generation antipsychotics. It's still out there. And now that we have treatments for TD, we can actually do something about it. So step number one is recognizing that you may have TD in your patient population.
Okay. With the step number one in terms of recognizing that you may have TD in your patient population, what would you recommend that clinicians do to routinely screen for TD? Particularly, if you will, perhaps some of our younger clinicians who aren't used to seeing TD, and maybe you're having the false belief that because they're using second generation or third generation D2 antagonists, for that matter, that they are not going to see TD or encounter it.
Well, one of the more illuminating things to do is to actually look at videotapes of people with TD to get sort of an idea of what movements you can expect to see. Some can be quite subtle, some more obvious. And now that we have FDA-approved treatments for TD, both companies are putting out their videos for educational purposes that are useful to take a look at. The other thing to do is to be mindful of recommendations from the American Psychiatric Association regarding ongoing monitoring of people taking antipsychotics. It's recommended that we monitor for tardive dyskinesia every year for those on second-generation antipsychotics, every 6 months for those on first-generation antipsychotics, and actually more often if you have risk factors. And it's not necessary to do the Abnormal Involuntary Movement Scale examination at each time. The guidance doesn't say you must do the aims, but it says you must assess. So what I would suggest doing is making sure that you're looking for abnormal movements, the choreoathetotic, arrhythmic movements that can occur in the face, in the upper extremities, lower extremities, and so on, and just take a look to see if they're there. Now, one of the issues is sometimes you won't see it at all unless you do activation maneuvers.
Okay.
So one of the things about TD is that it can vary over time. It's made worse with stress. And you can actually bring it on more easily if you ask patients to do what we call activation maneuvers. It's something that we've all been taught to do. We just have to remember to do it, like touching your thumb to your fingers repetitively. I would demonstrate that to my patient so they would know what I'm asking them to do, as well as when they stand up and place their arms in front of them to count backwards from 100 or recite the months backwards. And that's a cognitive activation maneuver. And sometimes we'll see the piano playing movements of the fingers when they're doing the mental task. Otherwise, those fingers remain still.
Okay. Well, as I'm listening to you, again, going back to what you said at the start, probably one of the biggest obstacles is just actually being aware and being willing to actually be aware that tardive dyskinesia can occur in your patients. But then what I heard, which I thought is very important, is that it's not just simply doing, if you will, the full-on AIM says you don't have to do that. You have to be aware. You have to know the guidelines, and just being aware and alert. And if you've actually looked at the videos or things of that nature, you're going to be able to engage your patients in a discussion about tardive dyskinesia and also screen for it more effectively. And it doesn't have to be something that is overly elaborately drawn out necessarily.
Absolutely. You know, you start screening when you look for your patient in the waiting room.
You know, that's exactly what I was thinking. I mean, that general observation,
Yes.
Because it's amazing that when we have something in our mind, what our eyes can actually see. So,
Absolutely.
and that's what I'm taking away from that part.
Yeah, and moreover, when they're walking to the examination room, because that walking is an activation maneuver. And so when someone is walking, I like to look at those hands to see if they're moving in an unusual way.
And you know, that is a really simple intervention, as opposed to having somebody, depending on where you practice, whether it is an outpatient clinic, whether it's a private practice, I'm just thinking out loud, go and greet your patient and walk into the office yourself, as opposed to maybe even having somebody do it. And then that in and of itself becomes a form of an observation.
Oh, absolutely. You know, I have a private practice that I've had for 30 years. I don't have any staff.
Okay, all right.
So I go get my patient from the waiting area. I have to do that. Now, when would I do a full-on abnormal involuntary movement scale examination? This question does come up. I do it when I see something that I'm suspicious about, and it may be TD. So then I'll do the full-on AIMS exam, which only takes 5 to 10 minutes. It's not very elaborate. It requires 2 chairs, basically, and I do that, and I would certainly do it to get a baseline before I initiate a treatment for TD. And I'd want to repeat the whole exam periodically when they are in treatment for TD, so I have a gauge of how well they're doing or not.
Okay, all right. Now, Dr. Citrome, when assessing and trying to determine treatment for tardive dyskinesia, can you talk to us a little bit about differentiating tardive dyskinesia from drug-induced Parkinsonism?
So this is very confusing to a lot of people, and to myself as well. How do we interpret movements that are occurring simultaneously, both rhythmic and arrhythmic? So TD is typically arrhythmic, doesn't follow a specific pattern, looks herky-jerky sort of thing. And drug-induced Parkinsonism is a rhythmic tremor, 3 to 6 cycles per second. That's what we would typically see. You can have actually both superimposed on each other. It becomes difficult to disentangle. But it is important to disentangle, because the treatments that we use for one will be different completely than for the other. So one of the things that I look at, do they have a shuffling gait? So a shuffling gait would make me think of drug-induced Parkinsonism. And the treatment for drug-induced Parkinsonism traditionally has been anticholinergic medicine, which actually can make TD worse. So here's the most difficult part of all this in terms of getting good outcomes for our patients. If we give cogentin or benztropine to someone for a movement problem, and it turns out that they have TD, we're making the TD worse. We're not getting the TD better in any way. If we look at the product label for benztropine, it says it's not indicated for the treatment of tardive dyskinesia, can make tardive dyskinesia worse. However, very useful in someone who has let's say, an acute dystonic reaction. I would want to treat that emergently, actually, and tide them over with benztropine until I can figure out, is there another antipsychotic I can prescribe? That's the other thing, too, is I don't want my patients to have drug-induced Parkinsonism, and it's not acceptable to treat it long-term with an anticholinergic.
You know, I think about, I guess, how many of us were trained in terms of reflexively using anticholinergics for a variety of movement conditions. And as you discuss this, I do think about patients that have been referred to my practice who have been on antipsychotics long term, and cogentin has just been reflexively continued, or anticholinergics continued. And hearing what you're saying is really bringing home the point that actually that could have just exacerbated the situation and made their tardive dyskinesia worse.
In fact, when we take a look at what was going on 20, 30 years ago, actually when I was being trained, I was told to start prophylactic benztropine when I started an antipsychotic. But all we had then were first-generation antipsychotics, and made some sense to avoid tremor, to avoid rigidity in particular, to avoid the unpleasant feelings that patients may have with antipsychotics. And we would use this long term. But it turns out we have second generation antipsychotics today that are not as associated with drug-induced Parkinsonism as the older agents. And amongst the second generation agents that we have today, they do vary in terms of propensity for drug-induced Parkinsonism, and some actually have practically zero drug-induced Parkinsonism. So I would gravitate to those for patients who are sensitive to movement disorders, and it accomplishes a few goals. One is you're actually going to decrease the risk for TD in the future, because the presence of drug-induced Parkinsonism is a marker for developing TD in the future. It makes it possible to avoid the use of anticholinergic medication, which by itself is also a marker for the future development of TD. But actually the most important reason not to use benztropine is that as an anticholinergic, it can impact memory, makes our patients dumb. So the cognitive impairment associated with the use of anticholinergic medication over the long run will impair our patients who are already impaired cognitively because of their underlying mental disorder. So we're doing patients no favors by prescribing them long-term benztropine when we can avoid it. You know, I wish they would put a skull and crossbones on the bottle of Cogentin and call it poison.
Okay.
Or at least put a Mr. Yuck sticker on it. You remember Mr. Yuck?
I do remember Mr. Yuck.
So these were green stickers that we were supposed to place on household things that we didn't want our kids to get into. And Mr. Yuck, you know, sticks his tongue out. Maybe Mr. Yuck has TD, I don't know. But if we think of benztropine as not really benign, then that's also going to be, for us to be able to overcome an obstacle in terms of the management of TD.
Mr. Yuck, I'm sure somebody in the audience is going to come up with a Mr. Yuck emoticon pretty soon or whatnot and put it next to an anticholinergic. Now, Dr. Citrome, I was wondering if you could share with us maybe some of your views on some of the treatments, the newer treatments, FDA-approved treatments for tardive dyskinesia, and any of your thoughts that you might have in regards to their use.
So I'm really pleased that we have actually 2 treatments approved by the FDA specifically for the treatment of tardive dyskinesia. Both of them are VMAT2 inhibitors. Now VMAT stands for vesicular monoamine transporter, and there's 2 types of these transporters. Type 2 is the one that we're interested in for TD, and both products that are available out there are selective VMAT2 inhibitors, and they're reversible inhibitors. It's not like in the old days of reserpine. I mean, some of the folks listening to this podcast may remember reserpine. It was a VMAT1 and VMAT2 irreversible inhibitor, depleted dopamine, depleted the monoamines, and would treat TD, but also create all sorts of havoc. I remember using reserpine in the old days in patients with treatment-resistant schizophrenia. Reserpine is no longer available in the US, no longer being made. And as a replacement, when the thought was that we still needed a drug like that, was to create tetrabenazine, which was approved in this country for Huntington's chorea, but not for TD. Although it seems to work for TD, and in several other countries is approved for TD. So what happened in the US was 2 different companies developed kind of more advanced versions, so to speak, of tetrabenazine. So we have a deuterated formulation of tetrabenazine called duotetrabenazine, which alters the molecule sufficiently so that it's better tolerated and easier to use. And then we have another drug called valbenazine, which actually can be looked upon as a prodrug of an active metabolite that we would see with tetrabenazine, but delivered in a controlled and consistent and predictable fashion. So we have 2 VMAT2 inhibitors that are easy to use, efficacious, well tolerated. This is a tremendous advance over what we had before, which was nothing.
Well, Dr. Citrome, I want to thank you for discussing with us tardive dyskinesia, and again, those big take-home points. First take-home point, your patients do have tardive dyskinesia. Be aware of it, look for it, screen for it, and you can do it just as simple through just observing your patients walk from the lobby to the exam room. Next point, which I thought was big, and I've heard this from other colleagues, look at a video so that you can familiarize yourself with the different forms of movement disorders. And my colleagues in neurology have always said that if you're not actually looking at this or seeing it on a daily basis, it's going to be very difficult. And then the third thing is, I'm going to go ahead and say it, but let's kind of start maybe putting a yuck, if you will, sticker or emoticon on the reflexive use of anticholinergic medications for the treatment of tardive dyskinesia because they're not indicated. And we should all work to familiarize ourselves with these two new FDA-approved treatments for tardive dyskinesia because we can give our patients a much better brand of service and treat them. So, Dr. Citrome, it has been a pleasure. I look forward to speaking with you again. I'm very curious about your views on second-generation antipsychotics and maybe how we might have fallen asleep at the wheel in terms of their propensity to potentially cause tardive dyskinesia. And I look forward to speaking with you again in the future, sir.
Well, thanks so much.
You've been listening to the MDedge Psychast with Dr. Lorenzo Norris. And now it's time for this week's edition of Dr. RK.
Hi, I'm Dr. Renee Kohansky for MDedge Psychast. The world was captivated and rejoiced in the successful Thailand rescue of the young soccer players and their coach. We also mourn the brave Navy SEAL Samarn Kunan, who gave the ultimate sacrifice in supporting this rescue. Samarn died attempting to deliver oxygen tanks to the trapped players and their coach. Bravery and courage are readily apparent in those who save lives and rush into harm's way. These dedicated men and women who function seemingly counter to self-preservation, demonstrating one of the more sophisticated traits of humanity, altruism. Bravery and courage has many shapes, however. We bear witness to it every day in one of its most understated forms. The courage of our patients to remove the rose-colored filters on themselves and their lives. Studies have shown we unconsciously engage in a phenomenon known as self-enhancement. We tend to see ourselves as more intelligent than other people, more generous, and even better looking. Psychotherapy asks our patients to do just the opposite. We ask them to share all those ugly underbelly truths that serve as the yin to the altruistic yang. Courage takes form in all the mundane aspects of daily living. The single mother who leaves college to support her child, the husband who remains at an unfulfilling job to pay the mortgage. And sometimes, courage is simply getting out of bed in the presence of an all-consuming depression to face another day. Or the willingness to take a medication that might cause weight gain, sedation, or any of the myriad of side effects for just a possibility, not even a promise, of improved mood or thinking. We ask our patients to look at their own lives without blame or fault and say, this is just not working, and the only thing that has any possibility of changing is me. And maybe even to look at the pain they may have caused other people. They share with us the scary dark places no one wants to acknowledge exist, let alone say out loud. They share their humanity in all its beauty and all its warts. We must never forget, being a psychiatrist is nothing less than a privilege, and remain ever humble to the sacred role entrusted to us. Nor should we ever forget the simple acts of courage our patients demonstrate every time they walk in our door. They allow us to contribute to their lives, and inevitably, in the process, they better us. I'm Dr. Renee Kohansky for MDedge Psychast.
Thanks for joining us on this edition of the MDedge Psychast. You can find past episodes at mdedge.com/psychiatry or wherever you get your podcasts. For Dr. Lorenzo Norris, Dr. Leslie Citrome, and Dr. Renee Kohansky, I'm Nick Andrews, and this is the MDedge Psychast.